So I've been dean 8 years, and I've in this room every quarter. This is where the University Board of Trustees meet, but I've never been on this side. I've only ever been on that side. It's very interesting. It's a nice room. It has all these portraits in the back, and I'm really pleased to formally welcome you to this conference today. I think it was 2 years ago or so when Stewards of Change came through Laura Morlock, who's here somewhere, and to talk about a partnership. And I was just so impressed with the work that you had done and the iconic story about interstate trucking and getting uniform licensing and whatnot. And it just struck me immediately that expertise and ability to solve big problems and not get hung up in barriers was a perfect background to take on the issues that you're taking on now. So this symposium just offers a great opportunity to advance interoperability. And it's a buzzword now. It wasn't a buzzword when you started doing this many years ago. But to look at, I'm a physician by background and was a practicing physician until I became dean. I'm an epidemiologist. And those of us who have practiced medicine know how fragmented healthcare is and how human services across the different silos that we have in government, private sector, and between state and local government. So I was really excited when you came to us with this idea of trying to solve these problems by bringing together the thought leaders who are here today and leaders from all the stakeholder groups, academia, government, industry, entrepreneurs, nonprofits, and tribes. So we're all aware, I think, and excited by the window of opportunity that the Affordable Care Act gives us, and the government funding that is linked to the Affordable Care Act. And these efforts, we talked a little bit about this at lunch and whether the incentives are well-placed or not well-placed, but there are incentives and tools for states and localities to connect across programmatic and funding silos to share information, provide more integrated services, and achieve better outcomes for its citizens. So this conversation, I guess, it's a national conversation, began about 8 years ago with the coming together of program leaders and advocates concerned about improving the sharing of data and services among child welfare agencies. But it's clear that was a problem and an important problem, but it's a much wider problem than just child welfare agencies, from population health management to mental health to aging services to homeless services. And the challenges are the same. The methodology that we need to solve them is the same. And in the local area here in Baltimore, states differ in how they're organized, but we have so many different service systems, Medicaid, food stamps, temporary aid to needy families, same clients. And my youngest daughter has autism. And one of the issues when you're a parent with autism is you're not going to be there forever to take care of the kid. So you have to take advantage of social services to try to ensure that your kid's going to be taken care of when you're not there. So I'm an MD, right? I'm dean of a school of public health. I was chair of a department of medicine, and I got to tell you, it's incredibly hard. You just can't imagine what it's like to try to get Medicare and Medicaid for your kid. And there's, from a population point of view, it seems that we put barriers in front of all these services, and maybe that saves us money, but boy, we waste a lot of money doing it. So I have a personal reason that I'm very excited about working with Stewards of Change. So. And again, when we look at our school, we have programs in about 120 countries around the world. And I only visit a small fraction of those programs, maybe 15 countries a year, which is far too much for my faculty. I always hear, if I'm in the school, they say, oh, you're in the country today. So, but we have I see the same issues there. We have these individual siloed programs that are designed to solve a problem. So PEPFAR is a great example. There's an emergency plan for AIDS relief. It solved that problem, but in doing so, it really, in many countries, harmed reproductive health services, primary care, because it stole resources and created a parallel structure. So this may be part of human nature, but I'm so happy that you're here today taking these on. I was saying at lunch that our president who came 3 years ago, talks about one university and how we need to break down the silos in one university. And when I saw the symposium agenda, I sent it to him as an example of the kinds of things that we need to be thinking about here in our own place. So we all know the challenge of the information age. We have more data than we ever had before, and it goes down to the diagnostic test, the voxel or pixel, up to healthcare systems. And now, with that big explosion in health IT, we have even more data, but we don't use it well. We don't share it. We don't let it talk to each other. And to do so, there's a big prize at the end if we can do that, and that's better healthcare, better services, better health for our population. To do that, it takes multidisciplinary efforts. It takes people like you who are willing and committed to take on this big problem, who don't look at the barriers, but look at the advantages and the prize that we'll get if we do it well. So that's the end of my formal welcome. I just want to say how happy I am that you're here. And now it's my happy duty to introduce a great friend and a great leader in our university, Don Steinwachs. So Don, for 10 years, Don has an undergraduate degree in engineering mathematics, a master's in systems engineering, and a PhD in operations research. And I met Don when he was a faculty member many years ago in the Department of Health Policy and Management. And then he later became chair of that department. I was head of general medicine in the School of Medicine. You just could not have had a better partner or a better advocate for our faculty and our fellows than Don Steinwachs. So at the end of 10 years, just as I became dean, he decided to step down as chair, which is no causal relationship. I begged him, by a year. Yeah, what was the cause? Really? So, but Don is a person who, within our university, is constantly selected for the toughest job. So right now he is chair of what used to be called the director of the Institute for Policy Studies, which was here in Homewood as a standalone siloed entity. There was a decision to bring that into our school within the Department of Health Policy and Management, and because of his leadership, that's happened. It's been, you talk about cultural differences and a variety of other differences. When the university had to decide to take a hard look at fringe benefits, which really gets close to home, they picked Don to lead that. Don served as interim provost, and he's had a host of other activities, and you can read about his research, health service research. He's had a seminal effect on the healthcare delivery for the seriously mentally ill. So I give you Don Steinwachs.
The nice thing is I can interpret the clapping as for you and me. Is that the way it goes? Well, I was told by Daniel I could take a few minutes both to welcome you on the part of now the Institute for Health and Social Policy. We changed the name when we moved it into the School of Public Health. And I wanted to tell you a little bit about the vision for that, and then make some comments about challenges you have, which I'm very enthusiastic about your ability to meet them, of really producing a health and social care system that works. So when we talk about public health, there are sort of three core areas, and one of them is policy and policy implementation. And so in many ways, it seemed like a natural to be able to bring some people who are part of a broad public policy institute into the school, but then you have to say, well, maybe our interest in public health policy needs to be broader. And so indeed, I think one of the things we see in that vision is the opportunity to get many of us to say, well, maybe it's not just specific public health regulations, maybe it's not just this program or that, but we ought to go back to think about what are the determinants of health. And we know genetics is part of it, but overwhelmingly it is the social environment, it's behavior, it's the things that we do every day in our lives. You look at the correlates and you say, what's the most important correlate for health? It's socioeconomic status. And that's education, being productive, being engaged in society. And so on the public health side, we see this as a great opportunity to collaborate with people that broadens that perception and think about that maybe every policy, not just HHS policies in the government and state, really have usually some impact, maybe secondary, tertiary, on health and well-being. So we now talk about outcomes like quality of life, productivity, in addition to health as part of that policy arena. So the dean mentioned, Mike Klag mentioned that a good part of my research has been dealing with delivery of health services, organization, financing, quality for people with severe, persistent mental illnesses. And so I wanted to suggest to you, and you probably don't need the suggestion, that in many ways they're sort of a group that has the greatest potential in my mind for you to have a huge impact on. And so some of you may be in states. In Maryland, it's true that Medicaid is struggling with integration of services. And so we have historically had a carve out for the psychiatric services, but all the disabled people with severe mental illnesses get their medical services within a Medicaid HMO. And you can't get much information back and forth between those, right? And then, as you know, these disorders, schizophrenia, major depression, hit many people if they're going to have a severe disorder in their teens and 20s. And so this is a lifetime experience. We're now much more hopeful than we ever have been before about the ability for recovery. Now, they may never be what they wanted to be, what their parents might have hoped they would be, but they can be work. They can be in competitive employment. They can be doing things and engaged in ways that I would say 20 years ago we'd have said, don't even bother. You can't do that. You can't make that kind of difference. And so when I started in this field, one of the things we did was we looked at needs and unmet needs for people with severe mental illness. And we asked both people who had mental illnesses, consumers, as well as we asked family members. And so, we thought, well, what are the most important ones to them? Well, the most important were ones that we, at that time, were very unsuccessful with. One we still are. One is people wanted jobs. They wanted to have real work. They didn't want to be in a workshop or a place that you just set them aside. So they wanted jobs. The other is they wanted friends and intimate relationships. And so many of these disorders make it very difficult unless you reach a certain state of recovery to do that. And so we still haven't been successful in that. On the jobs front, you should know that over that 20 or so years, we now have evidence-based interventions. Individualized place and support is one of them, where it's been shown you can take a person who has a severe mental illness who wants to work, and you can take anyone who wants to work, and you can get 40 to 70% of them into a competitive job placement. Now, generally, these are part-time because these individuals are on disability. They're getting SSI, SSDI, they're on Medicaid or Medicare and Medicaid, depending on whether it's which of those it is. So we made some progress one place, another. Where I spend my time being worried about the quality of the psychiatric care. About 10 years ago or so, someone pointed out to us, reminded us something we've actually known a long time, is that individuals with severe mental illnesses die prematurely. They're dying about 25 years sooner than you and I are. The life expectancy is around age 55, but they're dying of the same leading causes of death that you and I will die from. So it's not the direct effects of psychiatric illness. In the top 10 is suicide, but it's heart disease, it's diabetes, it's cancer. It's the same things that are in the top group. They're getting them earlier. They're not getting effective treatment. Many times there's huge delays in diagnosis. Many of them, at the time they're diagnosed, they're actually in the last stages of cancer because no one listens or they're not engaged in the system. Somewhere there are failures there. Many of these people need housing. They need income support. You and I know that when you look at homeless on the streets of most cities, 25, 50% of them are individuals with mental illnesses. And even though we think we've made a lot of progress, and we have, we still talk about the largest mental institution in this country is the Los Angeles jail. There are more people with mental illnesses there than any place else. So it seemed to me, which is my hypothesis, and I think you're going to play it out for me over the years to come, is that if you could make the health system and social system work for a group such as those people, the 2 to 4 million Americans who have severe and persistent mental illnesses, it would work for anyone because it really brings together the range of barriers of multiple chronic conditions and the challenges of people who find it hard, much as if you had autism, find it hard to engage others, find it hard to advocate for themselves, and become very dependent on having some structure, but they find it hard to interact with that personal structure. So thank you for what you're doing. Thank you for what we'll be doing, and I look forward to participating in this meeting.